started and respect everyone's time. We'll get started. My name is Sineva Hackman. I am a program coordinator for the Delta Regional Community Health Systems Development Program with the National Rural Health Resource Center. I'd like to welcome you all today to today's Learning Collaborative. We're really glad you could take the time to be here with us today. Before we get started, I'm just going to go over a few housekeeping details. When you call in, your phone line will be muted. To unmute or remute your phone line, press *2. And once you call in, please keep your computer speakers on mute to avoid any echo or feedback. You can communicate via the chat box at any time, which is located on the left-hand side of the screen. And today, a copy of today's webinar materials are directly right below that chat box in the file share box, where you can click on that and download those to your computer. Today's webinar will be recorded, and we have a few polling questions as well that we'll be bringing up before and after the webinar. And once the recording is uploaded to the website, we'll send that out to you all as well to have that readily available. Now I'd like to turn it over to Shannon to get us started.
Thanks, Sineva. Good morning, everyone. This is Shannon Norman, Program Specialist with the National Rural Health Resource Center. Thanks so much for joining us today. If we could, before we get started, I'd just like to take a moment and see who all has been able to join us this morning. If you could please take a moment to type your name and your organization into the chat box. And while you're doing that, I will just give a little bit of an overview of the purpose of today's webinar. On today's Hospital Clinic Learning Collaborative, Dr. Clint McKinney will be presenting on global budgeting. Rural healthcare delivery is being shaped by changes in payment policies and financing sources, continually evolving quality measures and expectations, and evolving models of care delivery. Success in this transformation requires high-performance rural health organizations. The Global Budget Initiative approach involves an annual expectation for revenue for all inpatient and hospital outpatient care in advance. Our speaker today, Dr. McKinney, has over 30 years of healthcare experience and is currently an associate professor in the Department of Health Management and Policy at the University of Iowa. He is also a member of the Rural Policy Research Institute, or RUPRI, Health Panel, Deputy Director of the RUPRI Center for Rural Health Policy Analysis, and Deputy Director of the Rural Telehealth Research Center. Prior to his positions at the University of Iowa, Dr. McKinney worked with nearly 50 rural providers and communities as a healthcare consultant. We are very pleased to have Dr. McKinney with us this morning. Before we begin with the presentation, though, we have a few pre-polling questions. Sineva, could you please pull up the polls? And we'll give everyone just a couple of minutes to respond to these. We'll give everyone just a couple of seconds more. Well, thank you, everyone, for participating in the polls. Sineva, if you wouldn't mind pulling up the slides. And without any further ado, I'll turn it over to Dr. McKinney to begin the presentation on global budgeting.
Thanks very much, Shannon and Sineva. Thank you all for having me speak to this clinical learning group. So today we'll talk a little bit about global budgets, and in particular hospital global budgets. And I'd like to start with this. That's the triple aim, because I think it's just so important. It's easy for me to understand, and I think if all of us were sitting down for a beer with friends or a glass of wine with family, we would probably all say that this is what we expect of the healthcare system, that it provides better patient care, that it improves our community health, and we use our hard-earned money wisely through smarter spending. But this talk is really about the financing part. It's the green part. It's the money part. And I hope we'll have a little bit of time to come back to the other two, and that's better care and improved community health, because actually I think they're more important. And in fact, some of you may even say, why on earth is this doctor talking about financing when he really should be talking about quality of care? Well, I kind of wondered the same thing until I became kind of jaded maybe into realizing that it's really the finances that drive this behemoth that's $3.3 trillion in our healthcare system. So unless we can talk about the financing system and the payment systems, it's hard for us to really understand the impacts on patient care. So let me kind of start with that and move to financing systems. Now, I've got a whole bunch listed here: global budgets and shared savings, fee-for-service, bundled payments. The key to this is that they're all financing systems, but all are critically important in the way that we deliver care. So let me start with kind of our roots. Our roots are in fee-for-service. Now, fee-for-service is a payment for an individual unit of service. Actually, there's about 8,000 or 10,000 of them in healthcare, and they're memorialized in the CPT manual. So each service that we have has an associated code for it, a CPT code, and there's 8,000 or 10,000 of them or something like that. And an important thing, especially if you're coming from a rural health clinic or a critical access hospital perspective, that cost-based reimbursement and prospective payment systems, PPS, are fee-for-service systems. And that is, if we increase our volumes, we do better financially. It's like widget productions. The more you kind of make, the more money you make. And whether that helps, hurts, or does nothing for the patient really doesn't matter in the financing mechanism. It's we want to do more. Now, it does reward industriousness, and it rewards efficiency, but the key under fee-for-service is volume. And again, kind of talking about that conversation that you might have with your family or friends, is this really the way you want your doctor or your nurse or your hospital to be rewarded for providing as many services as possible rather than care? In the fee-for-service, volume is the imperative, not care. So let me contrast that to what kind of our subject is today, and that's a global budget. So in contrast to fee-for-service, a global budget is a single, unchanging payment per fixed time period. Usually talk about it in a year, but often you'll hear about per month, per beneficiary per month, or per member per month. And if you change that kind of concept just a little bit to per person, that becomes capitation. So a great example of this is your health club. You know, actually, the beginning of the year wasn't all that long ago. Some of us made New Year's resolutions. Some of us joined a health club, plopped down our $300 for the year. And now, if you're the CFO of the health club, kind of what do you hope for? Well, you actually hope that nobody comes to your health club. They paid their $300. We don't want somebody coming in here dirtying up our showers, breaking our equipment, and breaking our laundry budget. So prevention becomes the key in this, keeping people out of the system, ideally with wellness. Again, not care. So you're probably noticing both in fee-for-service and its contrary global budgets, it's still not care isn't really the metric by which we're getting paid. And the reason is we don't have a good metric for care. We don't have the best metric for value yet. So we've kind of gone to these extremes of fee-for-service and global budgeting. I tend to believe, as it'll probably come through in my comments, that I think we need to be swinging more towards global budget than we do fee-for-service. But the point is, each of these different payment systems and all the permutations in between have certain impacts on our healthcare system. So let me talk just a little bit about that. And I'd like to start with kind of one of the truisms, maybe not just in healthcare, just a lot of things that we do. Form follows finance. Form follows finance. And what I mean by that is how we deliver care depends on how we are paid for care. Now, I'm not suggesting that all doctors, nurses, therapists, professionals, both administrative and clinical, are charlatans. But my point is that the way we're paid tends to motivate us in a certain direction, and it's that much more difficult for us to shift direction if the financial motivations aren't following that shift. Now, interestingly and importantly, I believe that healthcare reform is changing both payment and delivery. It's changing the incentive systems and slowly starting to change the way we deliver care. And I kind of talk about this in a continuum. And it's a continuum of transferring of financial risk from payers to providers. So let me kind of show you a graphic of that. So this is my financial risk continuum. Over on the left side is high payer risk. This is fee for service. And it's high payer risk because we as physicians and hospitals can actually induce demand. Economists call it inducing demand. It's a little bit like what you read on the back of the shampoo bottle, you know, rinse, lather, rinse, repeat. That repeat part, that's inducing demand. And we can certainly do that in fee-for-service. We can do it for good, or actually we can do it for ill. There's some evidence that more care does not translate to better care, does not translate to outcomes, but better outcomes. But trying to figure out what that is what's critical. And I think many of us would agree that we've probably taken the fee-for-service kind of model a little bit too far. Now, I'm not going to talk about the different permutations as we start to move towards high provider risk, which is total cost of care, in which we as the providers are responsible for caring for an entire group of patients or an entire community in all of its costs and permutations of health care and human services delivery. I'm going to kind of talk more about kind of where we are kind of in this global budget. So that's a little bit over there towards total cost of care. But before I get there, I'd like to do a little bit of time kind of talking about accounting. Now, again, I'm not an accountant, and that may show, but I know just kind of enough to be either dangerous or know where some of our motivations and incentives lie. So let me kind of talk a little bit about first costs, because I'll tell you, I see this kind of bantered around a lot. This word is used a lot, both in serious and casual conversation. And if one of the things I could ask you to remember from this webinar is to the next time you hear somebody talking about savings costs or that costs money, please ask, especially in healthcare, whose costs are you talking about? Are we talking about patient or family costs? Are we talking about taxpayer costs? Are we talking about costs to the insurer? Are we talking about costs to the doctor or the hospital? Or are we actually talking about cost to society, which is more like total cost of care? So please ask that question. Whose cost are we talking about when we say something saves costs or costs more money? The next important concept is what kind of cost. And this is pretty important, even though it sounds a little bit esoteric for those of you who are not accountants who don't have a background in accounting. It's really important in how we manage hospitals and clinics. So let's kind of talk about fixed and variable costs for just a moment. Fixed costs are those costs or expenses is another word that's used for costs that are constant regardless of the volume, regardless of the number of widgets you produce or the number of volume, or in our case, the number of services we provide. While variable costs change proportionally with the volume, change proportionally with the number of services that we provide. So let me use a quick and easy, simplistic example. example of a taxi. Let's assume that we have a taxi driver who has an income per year of $40,000 in fares. He also makes $10,000 in tips, so he has a total revenue or income of $50,000 per year. But in his particular taxi business, he also has a lease expense for his taxi of $4,000 a year, and in this particular year, he had fuel costs of $6,000. So we're interested in those expenses or those costs there. So I would ask the group, which of his expenses are fixed costs? Now, I can't see that all of your hands are going up right now, but I know all of you are answering, well, his lease costs are the fixed expenses, the fixed costs. And that's correct. They stay the same no matter how many fares or how many taxi runs he provides. But his fuel costs are variable, and they go up in proportion with the number of taxi runs that he makes. So again, we have fixed costs that don't change no matter how many services you provide or taxi runs you make. That's the lease in this particular case. And we have variable costs, which are the fuel in this particular example, that do change with the service volumes. Now, some of you may easily be able to think of a moment in a hospital, using a hospital as an example, of what examples of fixed and variable costs might be. Well, a fixed cost is the cost of maintaining the building. It's the cost of staff that need to be there whether we have patients or not, both administrative and clinical. It's the utilities. It's the insurance. Those are all the fixed costs in running, for example, a hospital. Variable costs aren't that much. We have probably medications. We have laundry. We have meals. We have tongue blades. But we really don't have that many variable costs in a hospital proportionally. This particular graph that I'm showing here with approximately 85% fixed costs and 15% variable costs is pretty accurate. It will vary some in a rural hospital. I've been working with a hospital in Pennsylvania, and the CEO is also the CFO, and he estimates that his fixed costs are a little bit over 90%. But the point is that we have a lot of fixed costs compared to variable, just like many heavy equipment manufacturers in the United States. Airlines, other than their fuel, at least in their equipment, are high fixed costs. So we're not all that different than some other economic sectors in the United States. Now, you might ask, why is all this stuff important? Well, let me kind of speak why it's important first from a fee-for-service standpoint, and then we'll go to the global budget standpoint as well. So what you see in front of you is my baseline fee-for-service example of variable costs, fixed costs, revenue, and profit. And you'll see three lines there. You'll see the revenue that goes up as we get more patients, going from left to right. We see our fixed costs as that red line. It's not changing no matter how many patients we have going from left to right. The fixed costs are not changing. And then we have to add to that our variable costs, which do go up as we get more patients. More tongue blades are being used. More laundry is being used. So what happens if a healthcare organization starts to get itself in a financial bind? What does the board and some of the less in-line leadership say to that organization? You need to cut costs. You need to cut expenses as the way for us to increase our profit. Well, we just learned that really what we can impact most easily in a organization is its variable costs. So let's see what happens to profit if we reduce our variable costs, and probably, by the way, driving everybody a little bit crazy along the way. We drop it down a little bit, and you see that our profit goes up just a teeny bit, not very much. So in the fee-for-service environment, the way to profitability is to increase volumes. Now, I got to stop and pause for a moment with a very important caveat. Please remember my background. I'm a background in clinical medicine. I'm very proud of that. And I think in my introduction, they said 30 years in medicine. Well, it's actually getting close to 40. And I'm very proud of my background as a rural primary care physician. I would never, ever recommend services that aren't necessary for the health of the patient and the community. But, you know, if everybody needs colon cancer screening in a community and you do a survey of 50 and find out only 50% of your community at age 50 have had colon cancer screening, well, there's an opportunity in fee-for-service to improve the health of the population and increase your volume, and thus increase your profit as well, too. So that's fee-for-service. The point in fee-for-service is it's very hard to increase your profit by simply lowering variable expenses. The more efficient, the better way is to increase the volume of clinically necessary services. So let's switch now to what a global budget looks like. Quite different, quite different. Now, what you see is the familiar red line is there, like we've all kind of talked about. And you also see that familiar variable line, which is our fixed plus our variable cost, the purple line. But you notice something's different here. The revenue. The revenue is the same, whether we provide less services or more services. Now, another caveat. In a capitated model, as opposed to a global budget, the more patients we have within our capitated system, actually the more money we'll make because we get one more patient, just like the health club. But this is an example of a hospital global budget. And in a hospital global budget, what we really see is we see that as we provide more services, our profit turns into a loss. And that's really important. Hold on just a second, Ellen. So I'll continue on. So what I'm really kind of talking about there is that as we move more services, we start to see more of a loss from our baseline or break even. If we provide less services, we actually make more profit. And we'll talk about that dynamic kind of as we go through here a little bit. But I want to talk about profit for a second and ask, how does one kind of make a profit? Well, first of all, not-for-profit organizations still must be profitable. There's a little bit of kind of argument about what percent of profit an organization needs. I heard an advisory board representative say once a not-for-profit hospital needs to make 4%. I heard someone else just say they need to make 2.5%. The point is that even not-for-profits must make a profit. Now, when we talk about this making a profit, I want to set aside for a moment, and we'll come back to this, the obligation of duty to serve the organizational mission. So in fee-for-service, the way we make a profit is actually to increase volumes, either in cost-based reimbursement or prospective payment. But what about capitation or a global budget? Let's kind of talk about that a little bit. So with a global budget, there's three primary roads to profitability, and remembering that profit is equal to revenue minus the cost. One way we do it is we try to reduce costs through decreased utilization. So that's reducing our variable costs. Now reducing that, what we call potentially avoidable utilization reduction, is challenging, as I just pointed out. It's hard to kind of make a profit through simply reducing variable costs because our variable costs aren't that high. We just don't have that many of them. If we take one patient out of our day in the ED when we normally see 20 patients in our emergency department, we're still paying the doctor, we're still paying the nurse, we're still paying the utilities, we're still paying the rent on the building, or debt on our building. Yeah, we're not doing as much laundry, we're not providing as many meds, and we're not using as many tongue blades. But the point is this is a challenging way to actually reduce our total costs. What about operational efficiency? Kind of like the Toyota Lean method. Actually, it's a very good way. And both Lean and its kind of cousins about operational proficiency, or efficiency, are actually beneficial both in fee-for-service and in capitated or global payment models. But the biggest way here is maintaining revenue despite negative trends. This is our biggest opportunity to do well from a financial standpoint within a global budget. So let me kind of show you that. A global budget has to be set at some level, and that is always key. You always need to ask, when you start thinking about a global budget, how will my global budget be set? Usually it's based on some sort of historical measure. It might be last year's revenue. It might be the average of the past 3 years' revenue. But it's usually some sort of historic value. So what I'm showing here is a trend, and I'm just using a kind of fictional critical access hospital that has $10 million in revenue, patient care revenue in 2016, and it's going down. And by 2019, the number is actually at $8 million of revenue. But between 2019 and 2020, a global budget is implemented. And with this global budget, which is the green line here, now our revenue stays constant at some historic value. And in this particular case, I use $9 million. But the point is that $9 million continues indefinitely, in parentheses, indefinitely, while our trend line is going down. So you can see the delta between our global budget and our fee-for-service or cost-based reimbursement trend line is actually positive because of the global budget. So we're experimenting with this idea of global budget in some places. Now, there's not that many. And I use this kind of map here just to show a few statewide healthcare payment reform examples. This is not exhaustive. I'm only going to highlight just 4 here and 2 in particular, but I wanted to give you some examples of where this is going on and where you can learn some more about this idea of alternatives to fee-for-service payment. So we'll kind of pick on Maryland, Oregon, Pennsylvania, and Vermont. Maryland has by far the most experience with this. Maryland has been using a hospital global budget for about the past 10 years, and it's built on its all-payer model. Now, you all may be familiar with this all-payer model, but it's unique among the 50 states. In Maryland, it doesn't matter if you're Medicare, Medicaid, Blue Cross Blue Shield, Aetna, whomever else the commercial payers are there, you pay exactly the same price for the same service. You don't have something that's different. Your charge master isn't different for every insurer, Medicare and Medicaid. It's all the same. And that's made it easier to implement kind of a global budget provided to hospitals. Now, this creates incentives for hospitals to actually coordinate care, to provide care in an outpatient setting. But it's only been recently that the Maryland program, actually this year, that the Maryland program has actually woven in physician services into their total cost of care model. Oregon also has a lot of experience with their CCOs, or coordinated care organizations. What's unique here is kind of partnerships between a payer, hospital, primary care providers, behavioral health, hopefully soon, I think, are coming dentists. So it's a partnership that operates under a global budget for Medicaid in Oregon that's been quite successful. Now, interestingly, kind of a sidebar around Oregon, and I think I have my data pretty accurate here. They've been successful at keeping their Medicaid cost inflation less than 3.5% per year, 8% per year. And so that's kind of the number they came up with. And they've been successful at keeping their inflation below that. But you might wonder, how did they do that? And interestingly, what they did was they lowered hospital costs a little bit. They lowered specialty costs a lot, and they increased primary care costs by like 19%. And by doing that, they actually saved the entire system money. So of course, as a primary care physician, that kind of is music to my ears, and also what we've all expected and talked about for probably decades. Now, the Pennsylvania Rural Health Model, that's where I'm working as a consultant, and also with the Rural Health Value Team. This is a CMMI demonstration that provides global budgets to participating rural hospitals in the states. And it is not the same as Maryland. They don't have everybody paying the same amount. So what is happening in Pennsylvania is each hospital has its individual global budget determined for every payer. So Medicare has a global budget for each hospital. The Blue Cross Blue Shield of Pennsylvania has its own budget for each hospital. UPMC, University of Pittsburgh Medical Center, its health plan has its own budget for each hospital. So it's different than Maryland in that each hospital has to be working with its payer to develop a unique global budget. So a hospital may have a half a dozen global budgets that it's working with. Now, this is pretty new. We're just kind of working with this. We've just had our first year with our first set of 5 hospitals. And so this is developing, and we'll kind of learn more about it as time goes by. The Vermont all-payer ACO model is very much like an accountable care organization. They're considered next-gen ACO participants, and it works kind of like an ACO that we won't get into too much. Now, some of your own states may actually be working, at least especially in Medicaid, around some statewide initiatives. The states are actually much more innovative right at this time than the federal government is. So you all may be able to add to this list and be able to kind of help shape the way this is moving in the United States. But I think most would agree that we are kind of moving along that continuum that I showed as a slide earlier, from kind of that high payer risk to high provider risk, but also that means higher provider control as well too. And I think this is an appropriate move for us to make. But there's a slip between the cup and the lip, and these kind of changes are not easy to do. And one of the changes that's necessary but not easy to do is to try to figure out, how do we put checks and balances on this global budget model? And you all in the audience may be kind of saying, well, that's all fine and good, Clint, but how do we keep hospitals or whomever has this global budget from stinting on care, denying care, withholding access or reducing access to care, or just even having a poor experience? I can tell you about this. Was done years ago, a look at cataract surgery rates. I think it was done in California in the 90s, where they looked at ophthalmologists who were being paid under a capitated contract versus ophthalmologists that were being paid under a fee-for-service contract. And almost as you'd expect, they found that the patients seeing the ophthalmologists under the fee-for-service contracts had their cataracts done about twice as often as those under the capitated contracts. Now, I think probably the right number was somewhere in between those two, but every time you see kind of a variation in utilization or even a variation in care that doesn't vary because of the individual patient, that's something we should be suspicious of. So I'm suspicious that in that particular example, patients who were under fee-for-service were getting their cataracts fixed more often than they really should have been, and patients under capitation were not getting their cataracts fixed as often as they should have been. So there's risks in both of these models. So then to come back to the question, what are the checks and balances on a global budget model? Well, the strategies that we're trying to employ and trying to develop are somewhat like we've done in the past. We have traditional quality metrics. We have population health and patient satisfaction experience metrics. You can still weave in bonuses and penalties for that particular kind of performance if you wish. And we also do market share analyses. Do we kind of watch markets, and if a particular organization is starting to lose market share in a global budget and that market is being taken up by someone else, that may tell me that particular organization under the global budget is actually kind of reducing access to care. So these are all important to make sure that no one is gaming the system and they're under development. So those of you who have ideas about how best to monitor a global budget, please send them my way, because we're trying to develop that in Pennsylvania right now. It's difficult, and it's important though. So these are kind of the checks and balances. Let's kind of also now talk about why would you even kind of agree to this? Why would you agree to doing a global budget? Well, I had a hospital CEO in Pennsylvania say to me that it provided him financial breathing room. I don't know the financial status of the hospitals or the clinics of the people on the phone, but across the country, critical access hospitals, and even more so, the tweener hospitals, many are in are financially challenged. So if in that situation, you might want to consider a global budget if you're seeing a downward trending patient revenue, kind of like that chart that I showed you earlier. If your trend is downward, and you can lock in your patient revenue at a rate despite a downward trend, that would be a positive reason to consider a global budget. What happens if you have very few patients in your service area? Remember, volume is king when it comes to fee-for-service and cost-based reimbursement. And you have very few patients in your service area, or they're declining, you have a declining population, then that may be another reason to consider a global budget that locks in historic revenue. And lastly, if you're simply financially distressed for reasons beyond your control, you still need to kind of think about operational efficiencies. You still need to think about that. You still need to think about good financial management. But we in rural are often in situations that are beyond our control: economic situations, population situations, demographic situations. And if we're financially distressed for things beyond our control, then a global budget to lock in historic revenue may be helpful. So conversely, where might it not be appropriate? Well, here's why I ask hospital leaders and clinic leaders to be honest, candid. If you can honestly and candidly say that I expect our patient revenue trends to continue to go up or to suddenly go up, then there's no reason to lock in historic revenue. In fact, it would be a mistake to lock in historic patient revenue. A global budget would not be helpful to you. But I'm not sure I found too many cohorts of individuals that are more optimistic about the future than hospital CEOs. They always believe they can increase their market share. So if you're one of those and you're being candid and honest, and you've shown a track record of being able to do that despite price trends starting to go down, well, global budget's not really for you, but you need to be honest. You need to be honest about that. So what would be some risks? And everybody should kind of think about this before you start embarking on this idea of global budget. Well, one of them would be if your volume does indeed go up unexpectedly. If you kind of would have had an opportunity to make more profit because your volumes went up, well, that would be lost potential revenue. Similarly, if your costs go up higher than you expect, then that would be a reason why you might not want to consider a global budget. And, you know, even if we do kind of lock in this historic revenue as I've been talking about, risks still remain. Reducing your costs is still difficult. Everybody says, well, what happens if they adjust my budget in the future? You know, that's always possible. We don't know the answer to those kind of questions if a payer is going to adjust our budget in the future. And then also this one, if your patient operating margins or your operating margins are a negative 10% and we're wildly successful to increase our profit margins by 5%, you're still negative 5%. So even if we block in our global revenue, it may not be enough for hospital survival. Oh, unless we think that we can suddenly get rid of our billing departments, not true. We still need to code claims. So we still need to submit bills. We need to do so for risk adjustment, for copays, and for quality assessments. So as much as I would like to be able to say we can really streamline our business operations in our hospital if we have a global budget, at least that's probably not true, at least initially. We'll see about that in the future, but we can't promise that at this time. And lastly, I want to end on this particular comment on this slide about hospital risks, is that many hospitals are already at risk. If we're seeing our operating revenue or even our total margins going down over time, that's a risk. And we all know, and we see it in the news, that, what's my number now, 130 hospitals in the past decade or so have closed. So, and the reasons for those closures are many, but almost all eventually come down to a financial one. So I'm going to argue that many of us already are at financial risk. So if we say global budgets are too risky, well, too risky compared to what is an important question. I also think there's some interesting advantages kind of beyond the finances in global budgets. This is a pretty exciting managerial challenge. Now, some people would be frightened by this. Some people would be energized by it. But imagine being able to work your hospital operations or your clinic operations with the sole purpose of improving the health of your community and reducing utilization of your hospital. Imagine that. Imagine that. Imagine how you would coach your department leadership, your managers. How would you do that differently than what we do right now, which from a financial perspective, we want the business. We kind of joke that, you know, hospitals, CFOs kind of like flu epidemics, but hospital CFOs in the global budgets really like community flu vaccine programs. That's the difference. And isn't that exciting to be able to get paid for community and population health care? And it allows us to focus more on our mission. You may remember that very early, maybe my second slide, kind of I talked about the triple aim, and the triple aim is providing better patient care, improving the health of the community, and using resources wisely. So wouldn't it be neat if all three of those worked together? That if we provided better care, if we improved the health of our community, we actually made more money? Wouldn't that be exciting to be able to do that? Wouldn't we be exciting to be able to balance our duty of improving the health of our community and ensuring our financial viability in the future be in lockstep? That's something new and different that global budgets theoretically can allow. We're still early in this. It's still hard to kind of sort out what are the growing pains and what's not. But theoretically, this is where we could move to. And to me, that's very exciting. And the reason why it's more exciting, I'll end my presentation on a little bit of talking about why I think this is kind of important for us to think about. Some of you may be familiar with this graphic or a variation of this graphic. It's good to remind ourselves that what we do in healthcare is really impacting roughly 20% of an individual's health. There are other factors that are as or more important than what we do. Despite the fact that we as a country spend $3.3 trillion on it, it's got to be like the fourth or fifth largest economy in the world just within healthcare of the United States. So should we as a community hospital start thinking about these other impacts on the health, on individuals' health? And of course, this is what's often talked about with social determinants of health, which is the darling right now of both conferences and publications and JAMA and Health Affairs and all sorts of different places. And I think it's very, very important that we consider it. We consider not only social determinants of health, because remember, this is the health of the communities in which we live and in which we practice and in which we operate our organizations, but we also need to think about the social needs of patients, which are different from the social determinants of health. And when we have a global budget, suddenly the connections to the social needs of patients become exquisitely important, financially important. How can we address these bullets that I have here? Poor nutrition, inactivity, mental illness, substance use, unsafe housing, isolation, care fragmentation. How can we address those in a way that provides better care, improves the health of our community? Oh, and by the way, makes it unnecessary to utilize hospital resources so we can enjoy the financial largesse of our global budget. New payment models may allow attention to these social needs of an individual and the social determinants of health that impact our community. It may allow us to start thinking about going beyond medical care, going upstream for health. Now, we should ask ourselves, are we as hospitals in a rural community the right organization to do this? Are we the right locus for health, not just medical care? Certainly, if you read the information from the American Hospital Association, and it's very good in my opinion, regarding redefining the H, they think it is. But I'm going to ask you kind of to be a little bit thoughtful for a second. Is community health, is improved population health the role of a hospital, the role of a doctor? I will say if we are paid to do it, it certainly is. If we are paid to deliver medical care, deliver widgets, do things to people, parentheses, whether it helps, hurts, or does nothing for them, well, I'm not so sure. I'd like to expand our horizon. I think that the brain trust in rural hospitals and rural healthcare organizations is the best locus for improving the health of a community, and I think it should be us who are doing that. But we need to be paid to do so, We need to be responsible for health